Hi, welcome to our channel of IGNOU Audiobooks. Indira Gandhi National Open University, School of Continuing Education, Bachelor's Degree Program, Elective Course, Gender Studies, BGSE-001 Gender Sensitization, Society, Culture and Change, Block 4 Health and Gender, Unit 11 Health in Social Contexts. 11.1 Introduction. It is important to know how health is perceived by all genders so that the health needs of each gender can be addressed. Universal Declaration of Human Rights, 1948, affirms right to health. This right to health is the core principle of WHO. In this unit, let us start discussing construction of health based on gender and learn about life cycle approach. Life cycle approach explains various stages in the development of human beings from infancy to adulthood. We have used Erickson model of developmental stages in human beings to discuss in stage-wise health-related sufferings of women. In addition to life cycle approach, mental health and health issues of LGBTQ are also dealt with in this unit. Let us look at the objectives of reading this unit. 11.2 Objectives. After reading this unit, you will be able to times define health, times explain issues of gender and health, times elaborate upon the construction of health based on gender, times discuss significance of mental health and times list health issues of non-normative sexualities. 11.3 Definitions. According to World Health Organization, WHO, health is a state of complete physical, mental, and social well-being. It is not merely the absence of disease or infirmity. This definition was adopted at the International Health Conference, New York, 19 to 22 June, 1946, signed on 22 July 1946 by the representatives of 61 states, official records of the WHO, number 2, p.100, and entered into force on 7 April, 1948. Health has various components: physical, mental, emotional, social, and sexual with the following characteristics. Times each component affects the distinct aspect of health. Times all components are interrelated. Times all components together determine the health of an individual. By glancing at the above definition and various related components, one can come to conclusion that health is a complete well-being of an individual. In the following subsection, let us try to understand two other concepts related to health, that is, well-being and quality of life. Further, the concept of mental health is also discussed. 11th March 2001 Quality of life. The concept has different meaning in philosophical, political, and health-related contexts. Health-related QOL includes physical, functional, social, and emotional well-being of an individual. Miles define quality of life, QOL, as an aggregate of a number of social and economic outputs received by groups or individuals, or as subjective evaluation of satisfaction. It is also called as well-being. The following small study conducted by Parthasarathi among Irula tribes in Nilgiri Hills gives clarity on the definition quality of life. In his study, he draws conclusion that the Irula tribes are satisfied with their practical needs such as food, shelter, and drinking water available in their locality. But outsiders have different perceptions when they look at Irula tribes' way of life. Members of the tribes are not comfortable with outsiders' interference in aesthetic, socio-cultural needs. In fact, they request not to observe their way of living to stay away from outside influences. This study shows that Irula tribes perceive quality of life based on the socio-economic outputs of their community. They are basically contented with their life. But outsiders view them subjectively and consider their life as not a quality life. According to UNESCO, 1977, QL is as an inclusive concept which includes all aspects of life, both the material needs and transcendental aspects like personality development, self-realization and healthy ecosystem. QL is operating at both micro and macro level. Quality of life at micro level includes food, shelter, clothing, drinking water, and disposable resources. Quality of life at macro level includes infrastructure facilities, transportation, safety of individuals, and responsive governance. QoL is measured through indicators. Blishan and Atkinson developed subjective and objective indicators. Objective indicators are food, clothing, and shelter and are observable. Subjective indicators are perceptions and evaluations of individuals' status through job, financial security, and standard of living, BGSE-001, Unit 25 and 26. 11th March 2002 Well-being. According to Merriam-Webster Dictionary, well-being means the state of being happy, healthy, or successful. Well-being is also defined as quality of life of an individual or other social units. Like quality of life, well-being of an individual is also seen through subjective and objective aspects. Subjective aspects are related to emotional or spiritual well-being. Objective aspects are related to physical health. Physical well-being can be measured through quantitative and qualitative aspects of women's life. These aspects include food intake, infrastructure facilities, access to health and education. In the following section, we shall learn about the concept of mental health. 11th March 2003 Mental health. Mental health is related to subjective emotions such as depression, anger, anxiety, or happiness which connote mental state of mind. It generally implies the following. Times control on emotions, which determines how one deals with adverse situations. Times sensitivity to the needs of others, which determines how one considers others' needs and requirements while making decisions. Times confidence in one's own abilities, self-esteem determines one going ahead in life. Times freedom from unnecessary tensions, anxieties, and worries which determines one dealing with situations with a sound mind. So far, we learnt a few concepts related to health. Let us now look at the health issues of women and men and analyze health from gender perspective. 11.4 Gender and Health. As seen earlier, gender differences and gender inequalities between women and men reflect in all aspects of life of women and place them in a disadvantageous position. It reflects on women's health too. Once you will come to know about the health status of women, you will realize the importance of taking significant measures to address their health needs. Health needs of women based on their age, ethnicity, religion, and socio-economic status may also differ. You have already studied in Unit 1 of this course about the gender roles and how women, men, girls, and boys assume and perform different roles in the society. Due to socio-cultural, biological, and physiological differences among genders, health needs of women, men, boys, girls, and LGBTQ also vary. So, it is important to address health issues from gender perspective. For example, as a socio-cultural constraint, women cannot travel long distance to hospitals clinic alone. This makes them at disadvantageous position by not addressing the same. Likewise, family and community do not allow women to decide their health on their own. Along with the patriarchy, unequal power, relations between men and women, social norms, lack of education, low employment opportunities, experience of violence prevent women from accessing quality health care facilities. The aforesaid factors adversely affect women's health, thus leading to health problems like malnutrition, poor reproductive health, and high morbidity and mortality rates. Considering these differences, it is important to formulate and implement gender-responsive policies related to health. Thus, the needs of specific vulnerable groups and differences of all groups in the society must be identified and addressed through health programs and policies to ensure their quality of health. Gender analysis is a methodology to identify needs of each group and their vulnerabilities. According to Candida March, in Smith and Maitre Mukhopadhyay, gender analysis explores and highlights the relationship of women and men in the society and the inequalities in those relationships by asking who does what, who has what, who decides, how, who gains, who loses. By asking these questions, it tries to explore power relations in the society, their operations within household, and their impact on the society and market. Gender analysis in health examines how biological and socio-cultural factors interact to influence health behavior, outcomes, and services. It also uncovers how gender inequality affects health and well-being. Check your progress. 1. Define health, well-being and quality of life, and gender analysis. 2. Write how does health concerns differ for men, women and people of other sexualities. Let us gain insights on the mode of construction of health. 11.5 How is health constructed? As we have seen in the previous units, gender roles and gender relations produce inequality between women and men. The production of inequality between women and men determines health-seeking behavior of women and men. Due to inequality between women and men in the family and society, women find it difficult to access health facilities. Let us see how gender determines health of women in a larger context. Due to the prevalence of inequality in production, reproduction, and societal roles, it is difficult for women to take decisions on every aspect of their life. Inequality starts early in their life. Family decides schooling and work vocation for girls. Secondly, it is difficult for women to decide how to lead their life and how to access health facilities. Even if women have access to health facilities, it is difficult for them to decide whether to avail health facilities or not, as they are socialized not to take decisions on their own. The World Conference on Human Rights in Vienna, 1993, noted that violence is the most common human rights violation on women. The gender-based violence, GBV, also affects overall health of women who are subjected to it. Women need nutritious food, clean water, safe housing, safe mobility, and accessible health facilities. Thus, health of women is determined by both external environment and personal environment. State, society, home and family determine women's health. Amartya Sen writes, burden of hardships falls disproportionately on women due to following 7 types of inequality. He traces inequality in the Indian context under the following headings with several examples. 1. Mortality inequality. 2. Natality inequality, prevailing sex-selective abortion and female infanticide. 3. Unequal facilities, lack of basic social infrastructure like schools and hospitals for women. 4. Special opportunity inequality. 5. Professional inequality. 6. Ownership inequality. 7. Household inequality. Women are less educated, possess less wealth, and are represented in low percentages in decision-making bodies like the parliament and the state assemblies. But their contribution towards production, reproduction, and community-based work is more and also noteworthy. Discrimination against a woman starts early in her life. Family tends to provide nutritious and sufficient food for a male child and give less quantity of food to a female child. When they grow up, family ensures enough quantity food for all male members in the family, and women and girls consume less if there is paucity of food in the family. According to a report by the United Nations Children's Emergency Fund, UNICEF, in the year 2011 on status of children in India, a profile, prevalence of anemia among currently married women and girls in the age group of 15 to 19 years is very high. About 56% of recently married women and girls in the age group 15 to 19 years have a lower hemoglobin level than 12 GDL. When it comes to education, family prefers to provide quality education to a male child rather than educating a girl child. Due to low education level and lack of skills, women get into informal employment with no social security, thus compromising their aspirations. Low education also restricts women's mobility and loss of control over their sexuality and reproductive capacity. Due to socialization process, women believe this to be natural. When we compare women girls with men boys, we find boys and men enjoy free mobility. Also, family and society encourage boys to pursue education and occupation according of their choice, whereas family and society decide and impose restrictions on women and they take decisions on behalf of them. Restrictions on women's mobility and impositions on women affect women's development. Also, low education makes women to accept early marriage. Low education combined with malnutrition nutritional deficiency make women to bear undernourished child. When they bear undernourished child, the child becomes malnourished too. This becomes a vicious cycle. In India, when we look at the health indicators like maternal mortality rate, MMR, infant mortality rate, IMR, sex ratio, life expectancy at birth of women, the numbers are high compared to other developing countries. Table 11.1 Few select health indicators. Due to various reasons, girls discontinue their education in before finishing school. Low education and illiteracy has direct impact on health of women. In this process, women lose their self-esteem and self-respect. They lack confidence. Apart from personal changes, it devalues their significance in the family and society. In the following section, you will read about the life cycle approach and how discrimination happens at each stage of women's life. 11.6 Life Cycle Approach. Human beings are born as infants and slowly pass through different stages and become adults. These stages constitute life cycle. A life cycle is defined as the developmental stages that occur during an organism's lifetime. A life cycle ends when an organism dies. Erik Erikson, famous psychologist, first published his 8-stage theory of human development in 1950 in his book Childhood and Society. Erikson developed his theory mainly from his extensive field research. He explains how personality and behavior develop in people. Table 11.2 shows Erikson's 8 psychosocial crisis stages and age at each life stage. Erikson believes that the psychosocial crisis mentioned in each stage affects human beings' development and personality. After looking at Erikson's stages of human development, let us see how women face crises in each stage. Infancy, 0 to 1 years soon after birth, a girl child faces the threat of female infanticide. Even if the girl child survives, she may get discriminated with, not getting nutritious food, and mothers not feeding girl child properly. Before birth, there is a prevalence of sex-selective abortion. Early childhood, toddler, and toilet training, 1 to 3 years, like infant stages, girls are discriminated on the basis of food, clothing, and the socialization process in this age too. Play age, preschool, nursery, -3 to 6 years, family may not prefer to send their girl child to play school. They may get discriminated for food, clothing, and medical care. School age, early school, 5-12 years, girls are socialized to take care of the younger siblings at this stage. If there is more work at home, girls are asked to discontinue their studies. In India, children, girls and boys, complete primary schooling at the age of 10. In many parts of the country, upper primary, high and higher secondary school may not be available in closer vicinity. In that case, family refuses to send the girl child for schooling to far away school. Girl children also face lack of medical aid. They may also face physical violence. Adolescence, puberty, teens ages, -9 to 18 years, girls attaining puberty need psychosocial counseling and medical attention to understand the puberty. Family and society do not address their need. Schools, communities, and governments at local level must help the girls to understand physical and physiological changes in their body. Young adult, courting, early parenthood, 18 to 30. As an adult and adolescent women, they may face the problem of early marriage, withdrawal of support to continue education, early and repeated pregnancy, sexual violence and domestic violence. Maternal health remains grave concern at this stage. The common cause for maternal deaths in India are hemorrhage, abortion, infection, obstructed labor, eclampsia, blood pressure during pregnancy, sepsis and anemia. Adulthood, 30 to 50 domestic and sexual violence, stress, triple burden are some of the issues women face during this period. Mature age, old age, 50 plus, like previous stage, violence is the major problem women face in this stage too. Family may abandon women too and may force to leave home. Box No. 1. Health-related problems faced by girls and women. Times prenatal ultrasounds to detect the sex of the unborn child and sex-selective abortions, battering during pregnancy. Times infancy and childhood female infanticide, differential access to physical, psychological, medical, educational, emotional, recreational opportunities meted out to girls, incest, sexual abuse by strangers, child marriage, genital mutilation, child trafficking and prostitution. Times adolescence early marriage, eve teasing, molestation, sexual harassment, rape, forced prostitutions and trafficking. Times reproductive years abuse of women by intimate partners, marital rape, domestic violence, dowry harassment, wife battery, sexual harassment at the workplace, abuse of women with disabilities, denial of the right to taking informed decision related to own reproductive health. Times old age sexual abuse of widows, increase in the domestic workload. The following case studies will help you to appreciate government initiatives of the state governments in India to address health concerns of all, especially women and children. The case study Tamil Nadu shows the overall improvement in public health. In this process, women and children are benefited, and important health indicators like maternal mortality rate, MMR, infant mortality rate, IMR, and child mortality rate, CMR, have been reduced. Let us now read a case study to see how health scenario can be changed by adopting a proactive approach. Case study 1. Tamil Nadu's public health system. The budgetary allocation for health in Tamil Nadu is roughly the same as that of national average. But infant and child mortality rates in Tamil Nadu are less than half the national average. Strengthening of public health by the successive state governments gave the desirable results. Secondly, Tamil Nadu is able to control the outbreak of epidemic diseases during monsoon seasons and natural disasters. Unlike other states in India, the government of Tamil Nadu has three separate health directorates, namely Medical Services, public health, and medical education. Separation of activities helps to concentrate on services specific to each directorate. Public health in Tamil Nadu has qualified doctors, and 40% of budget allocation from health department goes to public health. It attracted qualified personnel through well-established promotion structure. Grassroots workers in primary health center, PHC, and technical staff play critical role for awareness creation, control, and prevention of vector breeding. The focus on prevention of disease reflected even during tsunami in 2004 and again during floods in Chennai and coastal districts in the year 2013 and 2015. Tamil Nadu was able to control the spread of disease during above-mentioned disaster periods with the active support of field-based health workers. This initiative of the government of Tamil Nadu clearly shows that the state can effectively run the public health programs with limited resources. Let us now read another case study to understand how state intervention with community participation can improve people's health status, especially women and children. Case Study 2. Community Monitoring of Health Services in Maharashtra. The Government of India National Rural Health Mission, NRHM, envisages greater role of communities to monitor health care delivery through Rogi Kaliya Samitis, health committees. 9 states were chosen to implement a pilot project. Maharashtra is one of the pilot states. The main objectives of community-based monitoring, CBM, are to improve the delivery of health services and raise awareness of the community with regard to healthcare entitlements. The state government also supports CBM. Village Health, Water Supply, Nutrition and Sanitation Committees, VHC, are formed and trained by civil society organizations. They play a role to monitor delivery of health services to the community. In addition to that, people are encouraged to attend Jan Sunwais, public hearing meeting, to discuss and report the health services. Officials present at the meeting respond to people's queries and address their concerns too. In this way, community-based monitoring, CBM, improved the health services. It increased the attendance of the service providers. Immunization percentage has gone up. Excess charging has reduced. Confidence on public service delivery has improved. Increased number of patients access public health service system now. Reference: India Rural Development Report, 2012 to 2013. Check your progress too. 1. What is life cycle approach? 2. What are the problems women faced in adolescence years of their life? Let us now study health issues faced by non-normative sexualities. 11.7 Health issues for non-normative sexualities. Non-normative sexualities communities face lots of health issues because the existing community and public health system are not fully equipped to address the health issues of the LGBTQ. They are more vulnerable to communicable and non-communicable diseases like HIV/AIDS. Therefore, it is important that the non-normative sexualities should be able to access health facilities. Creating awareness among transgenders is also important. They must be made aware of the health consequences if they fail to avail of the modern health facilities. Services must also respond to the particular health needs of transgender community, including hormonal therapy, sexual reassignment surgery, and psychosocial counseling. The specific needs of transgender population in terms of HIV prevention, diagnostic testing, treatment, and care should be addressed. It is important to map the transgender communities as proper documentation of their population will be helpful to address their health needs. Let us review another case study to understand the situation at international level. Box No. 2. The Supreme Court of Nepal in 2007 ordered the government to end the system that barred Teshro-Linki or third-gender individuals from access to basic citizenship rights. Judges ordered the repeal of penalties against cross-dressing, as well as other legal reforms, noting that cross-dressing is within an individual's human right as freedom of expression. In 2014, Supreme Court of Nepal created the third gender status for hijras and transgender people. Law in Uruguay allows people over the age of 18 to change their names and sex in official documents since 2009. The Senate in Argentina unanimously approved the gender identity law. This law allows transgender people to access public or private healthcare plans. Under the same law, transgender people can change their birth certificates, national ID cards, and passports without a requirement for any diagnosis. Denmark followed the same model in 2014. Apart from this, it is necessary to give wide awareness among public and enforce protective laws. Ref. www.who. ITL 11.8 Mental Health. You have already read in subsection 1 of this unit about mental health. Let us read about a more detailed discussion on mental health. Men and women have differential power and control over socio-economic resources which favor men. Thus, women are found to be more susceptible to mental health disorders like depression, anxiety, somatic complaints, and high rates of morbidity. This is because of the pressure of performing gender-based roles, stress, and negative life experience and domination by men. Other gender-specific risk factors leading to mental disorders include gender-based violence, socioeconomic disadvantage, low or subordinate social status and rank, and continuous responsibility for the care of others. The high prevalence of sexual violence also affects mental health of women. Like women, men too face issues related to mental health. Alcohol dependence among men is twice as high as women. In developed countries, approximately 1 in 5 men and 1 in 12 women are found to be alcohol dependent during their life. Men are 3 times more likely to be diagnosed with antisocial personality disorder than women. There are no marked gender differences in the rates of severe mental disorders like schizophrenia and bipolar disorder that affect less than 2% of the population. Gender bias in addressing mental health. Gender bias occurs in the treatment of psychological disorders. Doctors are more likely to diagnose depression in women compared to men even though men and women have identical symptoms. Gender differences exist in the society with regard to seeking help for psychological disorder. Women are more likely to seek help and disclose mental health problems to their primary health care physician. On the other hand, men are more likely to seek a specialist and are the principal users of inpatient care. Men are more likely to disclose problems with alcohol use to their health care provider than to their family. Box No. 3. Health-related stereotypes. There are gender stereotypes concerning emotional problems in women and alcohol problems in men. It appears to reinforce social stigma and pose constraints to seeking help. Thus, are barriers to psychological disorder for accurate identification and treatment. Despite these differences, most women and men experiencing emotional distress and/or psychological disorder are neither identified nor treated by their doctors. Violence related to mental health problems is also poorly identified. Women are reluctant to disclose the history of violent victimization unless physicians ask about it directly. The complexity of violence-related health outcomes increases when victimization is undetected. In most centers, these patients are not recognized and therefore not treated. Communication between health workers and women patients is extremely authoritarian, then it becomes difficult for women to disclose psychological and emotional distress. When women tend to disclose their problems, many health workers tend to have gender biases which lead them to either overtreat or undertreat women. Let us now read about some related to mental health. Box 4. Mental health, the facts. 1. Depressive disorders account for close to 41.9% of the disability from neuropsychiatric disorders among women compared to 29.3% among men. 2. Leading mental health problems of the older adults are depression, organic brain syndromes, and dementias. Majority of these patients are women. 3. An estimated 80% of 50 million people affected by violent conflicts, civil wars, disasters, and displacement are women and children. 4. Lifetime prevalence rate of violence against women ranges from 16% to 50%. 5. At least 1 in 5 women suffer rape or attempted rape in their lifetime. Take up the following exercise before reading further. Check your progress. 3. Write short notes on 1. Gender and mental health. 2. List 2 stereotypes and 2 facts related to health issues of women. 11.9 Summing UP. We have read the definition of health and 2 related concepts, namely well-being and quality of life. You have learnt that in our society how health is constructed on the basis of gender. When we study gender and health, it is also important to know about mental health and health of the non-normative sexualities. Life cycle approach reflects how women face problems in each stage of their life. The last part of the unit deals with gender differences in addressing mental health issues in our society. 11.10 Keywords. Maternal mortality. Maternal mortality ratio is number of women who die from pregnancy-related causes while pregnant or within 42 days of pregnancy termination per 1 lakh. Live births. Infant mortality rate, number of infant deaths in a single year out of every 1,000 live births that year. Sex ratio. The sex ratio is the ratio of males to females in a population. 11.1 to Unit End questions. 1. Explain Erickson's model of life cycle and the problems faced by women in each cycle. 2. Briefly explain how health is constructed based on gender.
Thank you for watching. We will see you in the next video with the next chapter.